Am I audible? Hello? Hello?
Yes, ma'am.
Am I audible?
Yes, ma'am. Yes.
18 people are there. Shall we start?
Yes, ma'am.
Okay. Very good afternoon to all of you. So anyone can say what is your second theory paper? Name of the theory paper two? No idea. BNS 0.
Nursing management,
Yes.
critical care conditions.
Very good. Nursing management in critical care conditions. That is your BNS 032. So today we'll have a discussion regarding block 6 of nursing management in critical care conditions. In block 6, there are 6 units. Unit 1, burn. Unit 2, polytrauma, multi-organ failure, organ transplantation, trials and coding. Shock. Unit 3, shock, septicemia, multi-organ dysfunction syndrome, disseminated intravascular coagulopathy. Unit 4, drug overdose and poisoning, anaphylaxis. And Unit 5 is there, that is drowning. As much as possible, I will try to cover all these things. So let us start Unit 1, that is bond. All of you know what is bond? Let me know from your side. It's not audible, please say. Anyone can say or write in chat box what is bond. Please mute your mic. Soma, please mute your mic, Soma. Yes,
Madam,
Royal.
burn is injury to skin
Yes.
or organic tissue through
Hmm.
heat or radiation
Through heat or radiation, another
or
source is also
chemical
there.
chemical भी ହେଇପାରିବ madam.
Yes, chemical
Chemical
भी ହେଇପାରିବ,
electricity
electricity ହେଇପାରିବ, gas ବି ହେଇପାରିବ. Okay.
ଆଜ୍ଞା
So
madam.
have a look. This is a case of burn. So what is burn? Definition: the burn injury occurs when energy from a heat source is transferred to the tissue of the body. It may be transferred through conduction or electromagnetic radiation. The injuries that result from direct contact with or exposure to any thermal, chemical, electrical, or radiational source is termed as burn. All of you clear? What is burn? Burn is an injury that occurs when energy from a heat source is transferred to the tissue. So, whatever may be the source, the heat is transferred to the tissue of the body, and that heat is transferred through the process of conduction either or electromagnetic radiation, and the sources are thermal, chemical, electrical, radiational, etc. What is called? Look at the picture. Are you able to see? Hello?
ହଁ madam ଦେଖାଯାଉଛି.
Huh. So slide is visible.
Yes, ma'am.
So what is scald? The scald is a term used when burn is caused by hot liquids, that is water or oil. Hot liquids, if the cause of the burn is hot liquid, that is water or oil, or gases like steam, most commonly occurring from exposure of high temperature. For example, tap water, you are using the boil water for bathing. That is, if there is very hot water in the geyser and you suddenly you showers, you don't know there is high temperature, so there is a scald will be formation. Then spilled hot drinks. So it is clear what is scald. Scald is a term. It is like a burn and caused by the hot liquids or gases. So it's very common. Burn nowadays is very common and it causes what the impact of burn is. There will be pain, there will be fluid loss, hypothermia, scarring, disfigurement. You can look at the picture how the person looks like and shock MOD. What is the full form of MOD? What is the full form of MOD? Anyone can write chat box or can answer me. Multi-organ
Ma'am,
dysfunction.
multi-organ dysfunction.
Yes, very good. Then types of burn. So there are two types of burn, mostly primary injury and secondary injury. Immediate damage is caused by the burn, that is primary, but secondary is deleterious effect resulting from the primary injury. So direct contact, if there is a burn, that is a primary burn, and if after many days if it occurs, then that is the secondary injuries. Then what is the causes of burn? Thermal burn, chemical burn, electrical burn, radiational burn, and inhalation burn. So what is thermal burn? Let me know. Monica? Monica, please tell what is thermal burn?
And due to heat,
Madam,
ma'am.
excessive heat ହେଲେ madam ହବ ସେଟା।
Very good. So thermal burn exposure with or contact with the hot liquids, hot or heat, objects, residential fire, scald, etc. Then chemical. What are the name of the chemicals? Anyone can say? Let us have a discussion. I don't like for it's a lecture class. You have all these things you have taught in your previous degree level or diploma level. So if this is an discussion class, I think it will be better. So tell me name of certain chemicals that can cause burn. Manoranjan,
NHCO3 sore के तेजाब NHCO3
huh?
Ma'am, acid.
Acid,
Hmm?
definitely acid. So name of certain acids.
NHCO3
कौन सेटा हवा?
sodium hydrochloride
Sodium
N,
hydroxide,
sorry Na
NaOH,
NHCO3
sodium hydroxide, AgNO3. What is
hmm.
AgNO3? Royal.
Silver nitrate, madam.
Huh?
Silver
sodium
AgNO3.
nitrate.
hydroxide
Very good. Silver nitrate. HCl,
Yes, ma'am.
sodium
HCl.
Acid.
What
sodium
is
hydrochloride
HCl?
Hydrochloric acid.
Hydrochloric acid
Hydrochloric
madam।
acid,
Hydrochloric
ma'am.
acid. Yes. Then H2SO4. What is that?
Sulfuric acid.
Sulfuric acid.
Very good. Then HNO3.
Nitric acid.
Very good. So
Right.
these are the acids that can also cause burn. Then electrical. As you know, lightning, electrical, any short circuit. So there is passing of current, high voltage current, and can burn the tissue. Then radiation like ultraviolet, radioactive substance, X-ray, sunburn, etc. Then inhalation burn. These things you people didn't tell. Huh? Inhalation burn, like for example, There are certain smokes that can also cause poisoning to the lung tissue. So, have one classification of burn. So, anyone can tell me what are the classification of burn? Another classification. This classification is according to the causative agents of the burn. Then another way, how can you classify?
Degree
Cyan,
of burn. Ma'am, degree of burn.
very
As well,
degree
first
of
degree,
burn.
second
Then
degree, and third degree.
degree of burn. Then any other classification? Okay. So according to degree of burn, that is first degree burn, second degree burn, and third degree burn. First degree burn is called as superficial burn. Second degree burn is called as partial thickness, and third degree burn is called as full thickness. So let us have a look towards these pictures. So what is first degree burn? What is second degree burn and third degree burn? In first degree burn, there is epidermis. Okay, involvement of the epidermis, epidermis, hypodermis intact. In second degree burn, you can have epidermis and dermis will involve, and thirdly, all the layers are involved. Superficial or partial thickness burn or first degree burn, that is otherwise called as first degree burn or superficial partial thickness burn. So here only the layer of epidermis will be involved. For example, sunburn. So it's very sensitive to touch and skin blanching by light pressure. So what is the meaning of blanching? Blanching, anyone can tell? What is the meaning of blanching? Cyan, Priyanka?
मैम जब स्किन को प्रेस करते हैं छोड़ने के बाद वापस उसी उसमें नहीं आती है वो
No, that is turgor, skin turgidity. But here, if we press, there is appearance of pale color. Okay, pale color appearance. If we push or if we press the skin, that is blanching of light pressure. Then affect our layers of skin, causing pain, redness, and swelling. Skin is dry without blister. So here in superficial or partial thickness burn, there is no blister formation, and the healing time is about 3 to 6 days. A superficial layer may be peel off in 1 to 2 days. No scarring is there, no blister is there. Okay. Next, deep partial thickness burn or second degree burn. It affects both the epidermis as well as dermis, including the sweat glands and hair follicles. Clear? So there is severe pain than the first degree burn. There is redness, but there is pale. In first degree, there is pale color. If we press, then here blister will be there. Look at the picture. Sometimes the blisters break open looking the area wet, bright pink or cherry color. It takes 3 weeks to heal and consider minor if covers 15% of the BSA in adults. No scar formation. Here also no scar like first degree burn. But the difference between first degree and second degree is here is blister formation. Here both epidermis as well as the dermis is involved. And the healing time is more. Here more than it will take 3 weeks. But here how many? 1 to 2 days. But 3 to 6 days it will take peeling off 1 to 2 days. Next, full thickness burn or third degree burn. It affects all the layers epidermis, dermis, hypodermis, causing charring or translucent whitey or waxy white in color. Here, the organs, bones may be involved. It causes excessive scarring is there. So, scarring the formation is not in first degree and second degree, but here scar formation is there. No pain in the area. Healing depends on the type of burn. It needs skin grafting for healing. You know what is skin grafting? Yeah? So next, There is also 4-degree bond. So deep full thickness bond is there in third-degree bond, but along with all the characteristics of third-degree bonds, some more features like here, amputation may be needed. The without grafting is not only the solution. Here it may needed amputation. Look at the picture. And the wound is blackened, depressed, and loss of sensation completely. It damages the bones, tendons, muscles, underlying fascia, even if the nerve tissue. So this is the 4-degree bond. So have a picture the difference between the first degree, second degree, third degree, and 4-degree bond. So epidermis in first degree bond, in appearance, first degree only epidermis is involved. In second degree, epidermis as well as dermis. In third degree, epidermis, dermis as well as hypodermis involved. And the color or appearance is without a blister, without scarring in first degree. But in second degree, that is blisters. And also in third degree, there is scarring is there. Then pain according to pain perception. So in first degree, it's very painful. Second degree, painful, very sensitive to touch also. Insensate means kana. What is insensate? Can you tell me what is insensate pain? Samran, Hamid, Suma, anyone can tell? Insensate means decrease the sensation or decrease sensation. Sensory, decrease sensory perception. Okay. So she cannot feel pain. Then course of healing in first degree, it will takes 48 to 72 hours or 2 to 3 days. But in second degree, it will take 3 weeks as we have already discussed 21 days. But in third degree, more time than more than a month and autography is needed. But in fourth degree, there is extremely coarse autograph along with amputation also required. So next classification according to body surface area. That is rule of 9. All of you know these things. Rule of 9 introduced by Alexander Wallace. The system assigns percentage in multiples of 9. It's not applicable to children. In children, what is the formula we are using? Subhasmita or Susmita? Tell. Have participation. It's a two-way communication so that it will be more effective than the lecture class. Let me know from you people. That is rule of 5, isn't it? In children, there is rule of 5. So I think everybody have an idea regarding this rule of 9, and in the picture it is clearly mentioned. Head is 9%, 4.5 back and front. Then front chest is 18%, front and back. Abdomen or back is 18%. Total leg, one leg is 18%, both back and front. And hands, both back sides. And one hand 9%, both sides. And perineal area is 1%, total 100%. So according to this, we will calculate how many percentage of body surface area is involved in the bun. Next, learned and broader method. Anyone can say or any idea regarding this method of calculation of bun surface area? Yes or no? You have already taught in your GNM or degree level. Chandramani, you are there? You are here? So, no one can tell. Okay, so I'll explain. So, learned and Browder method, it is the most accurate, most precise method for calculation of burn. So, one can obtain a reliable estimate of the total body surface area bond. It recognizes the total body surface area of various anatomical parts by dividing the body into very small areas and providing an estimate of the proportion of the TBSA. The initial evaluation is made on the patient's arrival and then on second and third day because demarcation usually is not clear until then. So, anything can understood or not? It is more precise method and more accurate method than the rule of 9. And what is that? See here in rule of 9, we are calculating according to 9, applying 9, we are calculating the body surface area. But here, the total body is divided into anatomical part. Which anatomical part is involved? The scoring is there accordingly. So it's a clear picture I'm giving here. So have a look. This is the burn. That is area involved here. The total body is divided into different anatomical area like head, neck, anterior trunk, posterior trunk, right buttock, left buttock, genitalia, right upper arm, left upper arm, right lower arm, left lower arm, right hand, right thigh, right leg, right foot, and left foot. So this is the anatomical parts of the body, and in the upper level there is age. According to age, which area? For example, I'm giving. Come to the first line. That is, it's written head, area head, and birth to 1 year. If a victim age is 1 year and his head is involved, the score will give that is 19. And if that 1 year child having head 19 and if the neck is completely involved, will give a score that is 2. And if the right thigh is involved, we'll give the score 3.5. And total we can calculate and give the score. That is the accurate method. So in the top level there is age, but 1 year, 1 to 4 year, 5 to 9 years, 10 to 14 years, and 5 years, and then next is adult. Is it understood? Is it understood?
Yes, ma'am.
Okay. Chandramani? Chandramani?
हाँ मैम समझ गए हैं
Clear?
Yes ma'am, yes ma'am.
So this is which method? This is London-Browder method. So next, palm method is there. Calculation of burn, that is palm method. That is the size of the palm is 1% of the TBSA. So here, the total body surface area is calculated according to palm size. That is palmar method. Patient's palm. So whose palm? Not our palm, not the doctor's palm, not the nurse's palm. The palm is patient's palm. That is her own palm. Patient's palm including fingers. The fingers also included is equal to 1%. So if the area is 1 palm, then 1% burn. If 4 to 5 palm is involved, that is, if the area is like 10 palm, that is equal to palm of the 10 area of a 10 palm. That is, we will give the score 10%. Is it clear? So next, according to severity, the body surface area involved, the depth and the BSA is classified to mild, moderate, and severe burn. So in mild burn, all first degree burns and second degree burns coming under this category and less than 10% of the body surface area. So what is mild burn? Mild burn, all the first degree and the second degree burns are involved here and the total body surface area is less than 10%. Moderate burn involving hands, feet, face, genitalia and second degree burns more than second degree burn and 10 more than 10% total body surface area. And if the body so it is divided according to actually the body surface area. So less than 10 and more than 10 and more than 25 is categorized to mild, moderate or severe. So next, Jackson's burn formula. It is also another model or another method to calculate the burn. So accordingly, the burn area is divided into three zones. That is the zone of coagulation, zone of stasis, and zone of hyperemia. So what is zone of coagulation? The central portion of the burn, which is severely damaged. As you know, if there is a case of burn, definitely the central portion is severely damaged than the peripheral portions. So this tissue will not recover and will slough out in the course of time. It will take more time to finish. So there is zone of stasis. It is the peripheral zone or surrounding the area which is surrounds the coagulation zone. That is less damaged area where inflammation actually occurs. It may recover the course of time. And zone of hyperemia in favor of these conditions. So outer layer of the zone of stasis, that is this zone of hyperemia, which is shrinks, replaced by the zone of hyperemia. So in this is the three layers, that is zone of coagulation. You have the look. So zone of the central portion is zone of coagulation. Then the outer side is zone of stasis. Then the next layer also hyperemia. So this is the more severe ones. Then the outer layer, that is stasis layer. Then this is this layer. This will be shrink when there is recovery time. The shrinkage starts from here and recovery starts from the outer side. So it I am discussion करते no need to. So next, pathophysiology of one. So as a result of one, normal function of the skin will damage, resulting physiological alternation. This includes what pathophysiology will happen in case of one. That is first physiology involved loss of protection barrier. That is loss of epidermis and dermis, so that there is chances of infection is there. Then second physiology, body fluids escapes out. Last physiology, as the skin is impaired, so there is lack of temperature control and also there is destruction of the sweat and sebaceous glands and decrease in the sensory receptors as these are present on the superficial layers of the skin. So actually what these all things will happen in two stages, hypovolemic phase and diuretic phase. So what happens in hypovolemic phase? The hypovolemic phase, that is first 48 to 72 hours of burn injury. Rapid shift of fluid from vascular compartment to the interstitial spaces. As a result, peripheral edema of fluid, electrolyte and acid-base imbalance will be there. Increased capillary permeability leads to large amount of extracellular fluids. Sodium chloride and protein can pass through the burn area, resulting blister, local edema, and escape of fluid through an open wound. So actually this hypovolemic stage starts after 48 hours to 70 hours of burn injury, rapid shifting of the fluid from the vascular compartment to the tissue interstitial space so that there is edema. As the fluid escapes from the blood vessels and in between the cells or tissue, there is edema will be there and there is will loss of fluid. Though there is loss of fluid, so there is fluid imbalance, electrolyte imbalance, and acid base imbalance, resulting blisters, local edema, etc. Next, diuretic phase. So after 48 to 72 hours, this phase starts. That is, the fluid backs from interstitial to intravascular compartment again, and blood volume increases, leading to increased renal blood flow, and diuresis happens. So sometimes fluid overload and dehydration occurs. So why? If when we give treatment, then this state will be happens. That is the diuretic phases. So next, what is Bond syndrome? The Bond syndrome, that means the group of manifestations that we have already told. Fluid electrolyte imbalance syndrome means a group of signs and symptoms. So it's because of fluid imbalance, electrolyte imbalance, metabolic disturbance, bacterial infections, and complications from vital organs. So, what is the local and systemic effects of burn? The local effect, tissue damage, inflammation, infection, and the systemic effects, that is visible blood loss and edema, multi-organ failure, hand and neck problems like caused by inhalation injury. Then the systemic complications. So the systemic complications, that is gastric ulcer, duodenal ulcer. So it is more common in acid one. Hematomasis, weight loss, non-specific complications like UTI, DBD, pulmonary embolism, etc. Then diagnostic evaluation. So what will investigate? What are the things investigation should be done? So only few people are joining, 22 maximum. Some days 40, 41 or 37. Why rest of the people are not joining, attending the class? So we'll have a roll call at the end of the class. Okay. So what is systemic complication? It's over. Next, diagnostic evaluation, CBC, FBC. So diagnostic evaluation, any disease conditions or any disorders, first of all, we have to do two things, history collection as well as physical examination. So after that, we'll investigate. That is the most common thing, CBC, sodium, potassium, electrolyte, urea creatinine, FBG, and carboxyhemoglobin, that is serum electrolytes. I have already told, alkaline sodium phosphate, serum glucose level, serum albumin, as it is all things are losses through the burn. So urine also, presence of hemoglobin, albumin, then chest X-ray, bronchoscopy, and lung scan, ECG, etc. Next, coming to management of burn. So under management, the total management completes in three phases, like immediate management, intermediate management, long-term management. The immediate management is otherwise called as emergent management, intermediate, and the last long-term management is called as the rehabilitative management or rehabilitative phase. Then coming to first immediate phase or emergency phase, it will start 48 hours to 72 hours of unchained or burn to fluid resuscitation. Immediate phase means sudden, immediately after burn to fluid resuscitation, up to fluid resuscitation. That is for burn to 48 to 72 hours. Then intermediate after 48 to 72 hours to healing. Then long term, that's a rehabilitation phase after healing. But to maximize the pre-born capacity of the clients, this phase will continue. So coming to the intermediate phase or emergency phase, it includes first aid, prevention of shock, prevention of respiratory distress syndrome, detection of a burn injury, wound assessment, and initial care. So this is the first aid of a burn, that is for minor burn and for major burn. So for minor burn, stop the burning process. If the burn is not broken, pass cold water or soak in cool water. Reassure the patient for pain. Cover the burn area with sterile non-adhesive plaster. Protect the area from friction and pressure. Administration of the analgesic. But first aid for major burn, stop the burning process. First of all, stop the burning process or remove the client from the source of fire or source of burn. Make sure victim is breathing. If not, then start CPR. If the victim is breathing, cover the wound with sterile cloth. And if breathing is not also, you start to CPR. Avoid breaking blisters. Don't try to break the blisters. Protect the area from friction and pressure. If fingers are burned, separate with sterile and non-adhesive clothing. Why it is essential? So because in burns, the fingers, they will all the tissue will melt and there is a chances of contracture formations. So to avoid these things, we'll separate the fingers and with adhesive, non-sterile and non-adhesive clothing. To prevent shock, place the patient in proper position. Be vigilant that face, neck, and back been injured. To have a overlook that neck, back have injured or not, etc. Then the immediate management. So after first step, we'll go to immediate or emergency management. So that is CAB. You can follow airway, circulation, breathing, wound management, fluid resuscitation, pain control, and tetanus toxoid. So airway management. Mostly it's necessary in inhalation injury, face neck is injury, laryngeal edema, airway obstruction to be checked. Bronchial suctioning, administer bronchodilators, mucolytics, endotracheal intubation, ABG analysis, elevation of the head and chest by 20 to 30 degree, yearly hysterectomy in circumferential or limbs bones. So it is a non-invasive and painless procedure where patient is totally enclosed in a pressure chamber greater than 1 atmospheric pressure. It delivers 100%, that is hyperbaric oxygen therapy. You will give. It delivers 100% oxygen directly to the open moist wound. It is painless procedure and enhances healing. So next, fluid management. So airways management, many things are there also. You have to follow the CPR guidelines like advanced life support techniques. In the next, we will cover that things. Then fluid management, and if circulation is not made. So how will you check the airway? Airway is patency or not? I will check whether the airway is patency or not. That is two maneuver is there. What are these maneuvers? One is head tilt, chin lift, or jaw thrust maneuver. So any adult with more than 15% bond and the children with 10% bond need fluid resuscitation because of fluid evaporation through the open wound, edema, and blister formation. Generally, three types of fluids are given: colloids, plasma expander, electrolytes, crystalloids, then non-electrolytes like 5% electrolyte and crystalloid, that is NS, RL, etc. Next, the formula for giving fluid and fluid therapy. Consonance formula, that is RL 2 to 4 ml per kg of body weight per percentage of total body surface area bond. So what is, for example, if the body weight is 50 kg and total body surface area is also 40%. So we'll calculate 2 to 4 ml. For example, 4 ml into 50 into 40. So whatever may be the amount, the first half of the fluid is to be given. Suppose there is 2000 ml or 4000 ml. So half of that means out of 4000, 2000 will be given in the first 8 hours and remainder 2000 ml or 2 liters will be given for remaining 16 hours. Next, Evans formula. So according to this formula, colloids is given. The total colloid replacement therapy is 1 ml per kg of body weight per total body surface area. Electrolyte 1 ml per kg of body weight per total body surface area. Glucose 5% water, that is 2 liter for insensible loss. And day 1 have to be given in 8 hours and remaining 16 hours. And in day 2, half of the previous day colloids and electrolytes, all for insensible fluids replacement, maximum up to 10,000 ml given all over 24 hours. Whatever the fluid that will be given 24 hours. So this is the formula. Colloid, according to Evans formula, colloids, electrolytes, glucose, all things are given. So colloid, whatever the amount of colloid, 1 ml per kg per body, total body surface area, that is 1 ml per kg per percentage of BSA, and glucose 2 liters. So Brook and Army formula. Brook Army formula, colloid 0.5 ml per kg into kg body weight into percentage of body surface area, electrolytes 1.5 into percentage of body, then glucose 2000 ml, and day 1 have to be given in 8 hours, remaining next in 16 hours, and day 2 half of the colloids, half of the electrolytes, all in terms of food therapy. Instruction: second and third degree bonds exceeding 50% of BSA are calculated on the basis of 50% of BSA. So wound management. So what is the wound management? So first one, airway, breathing, circulation manage. Then they have to cover for the fluid replacement. Then management is wound management. So in wound management, initial assessment, that is debridement, cleansing and dressing should be done. The cleanse the wound to eliminate or decrease the dead tissue and debris that serves as the media for bacterial growth to prevent further destruction of the viable tissue, provide patient comfort. Then circumferential wounds of disease, limbs of chest may be need urgent stereotomy. That means removal of the dead tissue through surgical procedures. Then wounds to be evaluated till healing. So analgesics and sedation or painkiller is for pain control. Analgesic and sedation we have to give. So simple analgesic like ibuprofen, acetaminophen, and narcotics to be administered. Then local anesthesia may be given. Intravenous narcotics, analgesics, and sedatives may be administered in small and frequent doses. In mild, the pain score 0 to 3, paracetamol and naproxen. In moderate pain score 4 to 7, that is tapentadol and their upward is be given. Then for severe, that is serum upwards and pregabalin, etc. can be given. Then tetanus toxoid should be administered. Next, after immediate phase, next phase is intermediate phase or acute phase. So management divided into 3 pages or 4 pages. It will include the first aid. So first aid, then emergency phase, then acute period or intermediate. So it starts at the end of emergency phase. So after emergency phase is over, next this phase, that is acute phase and intermediate phase will be there. In partial thickness bond, it will take, this phase will continue for 10 to 20 days. In full thickness bonds, this phase will continue for months. Next. So in this phase, the management consisting of infection prevention, topical antibiotic, wound care, and wound covering. So for prevent infection, the sepsis can occur 50 to 60% of bond deaths with microbials. So to prevent infections, and the most common infective agents are E. coli, Streptococcus, Pseudomonas, and Klebsiella group of microbes. Then true culture actually needed, and accordingly we should provide antibiotics. So systemic antibiotics to be given after sensitive test, infection control. So before administering antibiotic, it should have the sensitive test. Infection control measures to be taken while dressing with wearing PPE. Dressing should be changed every alternate day or every 1 to 3 every 1 to 3 days times per day in intermediate phase. Then running water over the burns periodically and skin grafting. So next, topical antibiotics. So the topical antibiotic most common use, all of you know, that is the silver nitrate or silver sulfadiazine, mefenide acetate, and mupirocin, mycostatin, statin, and um, bacitracin. So each has its own advantage and disadvantage. Next, wound care. Until complete re-epithelialization or re-healing is there, the bond dressing should continue and it serves a number of functions. So, what is the benefit of bond dressing? So, always the wound should not be open; it should be covered. The benefits are it will protect from micro invasion. It will minimize the metabolic losses. It limits the pain of exposure burn surface area. It hides the wound to help prevent adverse psychological response also. If the wound will be open, then the person who will be affected, she might have seen the wound, how deep it will be, and there is impairment of the psychology. So, wound care covers the area, topical antibiotic prophylaxis, occlusive dressing, and improved sterility. So, different types of wound covering is there, like open dressing, closed dressing, bland dressing, tubing. So, biological wound dressing is also there, like skin grafting, synthetic dressing, skin substitutes, and surgical treatments. Open wound dressing means wound to be exposed, but the patient is allowed to remain within the mosquito net. Close method or close. Here, the wound is covered with antimicrobial agent along with elastic bandage by wrapping the bandage and generally with new skin graft, sometimes grafting also done. Then bland dressing. This is the traditional method. So gauze sheets would be applied with ghee and some one part of 2 parts of honey and 1 part of ghee that will pour in a gauze and it should be wrapped over the burn area and the dressing should be changed every second day when it is soiled. Then tubing like hydro therapy, regular immersion of patients in water. Most burn units nowadays avoid this process because tubing can be helpful to clean wounds and gently stir as it separates. Biological dressings, as you know, biological dressings have an antimicrobial properties rather they create a wound environment, uh, etc. And to reduce the loss of heat, water, and protein and red blood cells and promote more rapid wound healing. Then is skin grafting, as you know, grafting has a major role to cover the burn wound and speed healing. Grafting is has a great importance to prevent also contracture, to shorten the convalescence and shorten the recovery period. It reduces the chance of infection. It will prevent the loss of heat, water vapors from the open wound. And there are grafting at 3 grafts. One is autograft, homograft, or allograft, and heterograft. Autograft means, as you know, grafting from the same person, and homo or allograft from the same species and from a cadaver also. 6 to 24 hours after death you can take, and from the heterograph means from the other species like animals. But homograph from other anyone from relatives or any cadavers etc. That is called as homograft or allograft. Then synthetic distance, biobrain, a nylon material, inticida. They provide wound protection from discussion and contamination, increase rate of wound healing, and reduce patient comfort. This composed of bovine collagen, you know, that is the bovine collagen, that is glycosaminoglycan, that is from the bovine pigs, and inner surface provided good wound adherence and the outer provides prevention against the exogenous bacterial contamination. Spontaneous dislodging and split skin grafting. Early excision of a burn wound with skin graft or flap. Then skin substitute. So this is also exogenous bacterial control prevent exogenous bacterial. Inner surface provide good wound adherence and the outer provides same like that bovine. So next surgical treatment, as you know, grafting is there. Early excision of burn wound with skin graft of flap. Next, that is the third phase. The third phase starts after the which phase? Intermediate phase. So acute phase, after acute phase or intermediate phase, the third phase, that is the rehabilitation period or long-term phase of burn management. That will start. The program should start early, preferable the day of injury, avoid prolonged period of immobility, and any body parts that is able to move freely should be moved frequently. So actually physiotherapy includes in these parts because and this should be planned. Actually it will start after acute or intermediate phase, but it should be planned at the time of injury. If there is severe burn at the time of injury, it should be planned how it will be given when the time will come. Then ROM exercise, range of motion exercise should be start from the day of injury. There should planned program of daily activities and rehabilitation center. The plan should be reviewed daily as the rehabilitation needs to change. Next, what is the complication of burn? There is infection, there is low blood volume or hypovolemia, hypothermia, breathing problems, scarring, musculoskeletal problems, etc. Multi-organ, even if multi-organ failure, sepsis, septicemia, and death will be occurs. Then what is the health education for exercise and ambulation? Exercise for prevention of contraction are begun soon the patient's condition is stable. The exercise should be active daily, gradually increase the duration. Suddenly, you should not start the vigorous exercise. It should be gradually increase the duration. The physical and occupational therapy should be given. You have seen the case of contracture. Look at the middle finger, middle picture, how the fingers are close to each other. Next, therapeutic positioning. Placing the patient's body parts in anti-deformity position, prevent contracture, prevent positioning is to be there. Then nutrition therapy. Diet has a major role for healing and recovery. So the patient should be advised to take high calorie protein and nutrient. High protein has a major role, as you know, for tissue repairment. High carbohydrate, fat or fatty acids and energy, and high level, increased vitamin, that is vitamin C and vitamin E, and zinc has a major role in wound healing. So this is all about burn. So are you understood?
Yes, ma'am.
Next we will proceed. Yes. So next is polytrauma. So what is polytrauma? Have a look to the picture. Disaster, huh? Or any accident. So what is polytrauma? What do you mean by? San, tell me.
One and more accident happen maybe on the road or any accident, more accidents.
Actually, not clearly audible. So can you repeat?
One and more road traffic accident or one
Okay,
and
okay,
more.
okay. Good, good, good. So polytrauma, we'll discuss sir, what is the definition of polytrauma, what is the epidemiology, what is the pathophysiology, then types of shock in polytrauma, management of trauma. The term trauma describes a variety of injury which pose a major challenges for pre-hospital care, emergency care, critical care, surgical care, and rehabilitation of a patient with trauma. Trauma has a challenge for the hospital care, for emergency care, for critical care, for surgical care, and rehabilitation care. Trauma means injury to the human tissue. So it is defined as intentional or unintentional wounds or injury. Maybe intentional, maybe non-intentional wounds or injury inflicted on the human body from a particular mechanical that exceeds mechanical mechanism that exceeds the body's ability to protect itself from the injury. It's maybe trauma is an situation or it is an event that occurs intentionally or unintentionally. Maybe wounds, maybe injury. When the patient's body cannot able to tolerate the cannot able to tolerate the force or the pressures, that is called as trauma. So polytrauma. What is polytrauma? Polytrauma is significant injury in at least two of the following six bodies. All of you clear what is trauma? Then what is polytrauma means 1, 2, 3, 4, 5, 6. There are 6 points. So 6 regions. These are divided into 6 regions like head, neck, face, cervical spine, one region, face is one region, chest and thoracic spine, one region, abdomen and lumbar spine, one region, limbs and bony pelvis, one region, external skin significant, that is one region. So out of 6 region, if at least 2 of these following things are injured, that is called as polytrauma. Clear? If there is
Yes, ma'am.
chest and
Yes,
thoracic
ma'am.
spine, okay, at least 2, more than 2 or more than two regions are involved or injured, that is called as polytrauma. And in injury polytrauma, the AIC score is greater than equal to 3. So what is AIC score? Abbreviated injured score or anatomical injured score. So, what is polytrauma? Polytrauma is an expanded to include concurrent injury to 2 or more body parts or the systems that results in cognitive, physical, psychological, or other psychological impairment. So, for example, TBI in combination with other disabling conditions like amputation, auditory and visual impairment, post traumatic stress disorder, ଏ ସବୁ ମିଶିକି ରହିଲା ଦି ତିନିଟା psychologically, physically or social cognitive impairment more than 2 or more body parts, that is also called as systems or body parts. That, for example, there is physical, psychological and cognitive impairment, that will also comes under polytrauma. So abbreviated injury score, that is AIS, and injury severity score, that is ISS. There is a region. You have one look, there is region, there is injury of description, that is AIS score, and square top of the 3, then ISS will be there. Okay, understood? From picture it is understood. If the region head and neck is involved, the injury description like cerebral contusion. AI score is given 3. So the face, no injury, 0. Chest, flat chest, 4. Abdomen, minor contusion or liver complex ruptures, 5. Extremity fracture, 3. External but no injury of the extremity, that is given 0. So whatever the total AIS, you have to do score. After that, square of top 3, that will be ISS, that is 50. Even an example is given. If AI score is 1, the injury is minor. If AI score is 2, that is moderate. If AI score is 3, that is serious. 4 is severe, 5 is critical, and if 6, then survivable. Understood? Yes or no?
Yes, madam. Yes.
Okay. So criteria for polytrauma include any one of the following conditions. There is another way of classifying the polytrauma, that is 2 major system plus 1 major limb one major system plus two major limb, one major system injury plus one open grade 3 skeletal injury, open grade 3 skeletal injury, or unstable pelvis with associated visceral injury. এই চারটা ভিতରୁ out of these four things also, if one is there, any one, so it is also included under polytrauma. The golden hour for managing the polytrauma. The golden hour rules was discovered by R. Adams Cowley. He told that the first 60 minutes or first 1 hour after the occurrence of the multi-system trauma is very vital, and he told this is the golden hour. The victim chances of survival are greatest if they receive the definite care in these hours within the first hour after a severe injury. So let's have discussion. You will already know what is polytrauma, what is the classification. Next, what is the etiology or polytrauma. RTA, you know RTA, road traffic accident, fall from height, aeroplane crashes, train derailment, assault, blast. Assault, you know assault? Yes, sharp injury with knife or with something that is thermal or chemical injury. Then polytrauma is the third most common cause of death in all the age group. The first peak major neurological or vascular injury, second peak intracranial hematoma is the major thoracic or abdominal injury, third peak sepsis and multi-organ failure. So out of polytrauma in the world, that is the third most common cause of death, and out of these three, that is first peak is a neurological or vascular injury, due to that death occurs. Second leading cause of death is for polytrauma, that is the intracranial hematoma, and third leading cause is sepsis or MOD, that is because of polytrauma will be the leading cause of death. You will have an look towards this picture. If immediate primordial distribution of trauma deaths, golden hours, how it will save, immediate management 50%, 30% life save, and 20% life will be there. Then trauma will also, you know, what different types of trauma is there: blunt trauma, rapid dissolution, bone trauma, polytrauma. We need not to discuss all these things. So pathophysiology, after etiology, we would have a discussion regarding pathophysiology of polytrauma. So it's a complex phenomenon. Polytrauma is not a simple, rather than it's a complex phenomenon, and its aim is to restoration of homeostasis and preservation of life. So according to etiology, there is primary insult and secondary insult. Trauma of the organ, direct injury, then after it leads to secondary injury. For example, if there is severe damage, there is hemothorax. Then after secondary injury means there is ischemia and hypoperfusion, decrease afterload or preload. So this is the secondary insult. So this includes hyperinflammation or hypoinflammation, that is SARS, systemic inflammatory response syndrome, then multi-organ failure. This is the pathophysiology. So what is SARS? SARS is systematic inflammatory response syndrome. So two or more findings out of these four, if two or more characteristics are there, it is included under SARS. If after polytrauma, out of these four characteristics, temperature more than 38 degree, heart rate more than 19, rate of respiration more than 20, and WBC more than 12,000, this is the four characteristics, and if two or more are there, then it is a case of after polytrauma, the patient is going to SARS, that is the systemic inflammatory response syndrome. Signs symptoms. The polytrauma signs symptoms clinical manifesto will be related to systemic involvement. Yes. So which organ will be involved according to systems? If cardiac systems is there, tachycardia, decreased systolic pressure, narrowing pulse pressure, cardiac failure, skin cool and calm, pale, cyanotic, central nervous systems, anxiety, restlessness, confusion, altered sensorium, decreased level of consciousness, renal system, decrease. It is because of trauma means because of many systems involved. Fracture is be there, fluid loss will be there, then maybe neurological disturbance is there. So in the renal system, decrease urine shock, severe blood loss, then after shock, then renal failure, decreased glomerular filtration, increased level of blood urea nitrogen, serum creatinine, acute or chronic renal failure. If the acute renal failure, the shock is not treated as soon as possible, the patient may be permanently occurs the chronic renal failures. Then pulmonary tachypnea, increased pulmonary capillary permeability, hepatic systems, decreased manufacturer or clotting factors, impaired drug metabolism, decreased synthesis of plasma protein, reduced serum glucose level, reduced elimination of ammonia, and phagocytosis decrease. Gastrointestinal systems, a dynamic ileus, ulceration, decreased absorption of nutrients, increased toxins, passing from lumen to bloodstream, vascular system, DIC, that is disseminated intravascular coagulopathy, cellular system, and anaerobic metabolism, that is lactic acidosis. So what is the complications? Complications, immediate complications, early complications, and late complications. Immediate, 50% of patients die within minutes due to brain system, brain stem, and high spinal cord injury. The laceration, cardiac rupture, and transection of the great vessels, airway obstruction, death will be there. Then early complications. 30% of the patient die within hours of injury due to severe head injury. Then massive blood loss within the chest or abdominal cavity due to severe hypothermia is there, metabolic acidosis, coagulopathy is there. Then in late complication, 20% of the patient die within few weeks after trauma due to continuous bleeding from inadequate hemostasis or undiagnosed injury or infection. Then adult respiratory distress syndrome and multi-organ failure will be the late complication. Remember, all the complication divided into three categories: immediate, early, and late complications. 50% patient out of, if total polytrauma patient will be categorized to 100%, then 50% will be immediate complication, 30% having early complication, and 20% having late complications. The late complication includes multi-organ failure, ARDS, and even if death. Then what is the diagnostics test for polytrauma? History collection, physical examination, the blood test routine, that is CBC, sodium potassium, urea creatinine, BUN, then X-ray, cervical spine, as in case of early trauma, there will be spine injury suspected. The spine should not be, it should be keep intact. Then if spine fracture or injury will be there, the chances of shock is there. Then ultrasound, if abdominal injury is there, CT scan of the head and abdomen, arteriography, MRI of the spine and brain, routine blood test, etc. Then different types of shock is there in polytrauma. As you know, hemorrhagic shock, neurogenic shock, hypoxic shock, and septic shock. So I need not to be explain all these things. Because of fluid loss or blood loss, that is hemorrhagic. Neurogenic due to spinal cord injury. Due to fluid and blood loss, that is hypoxia also, hypovolemic shock, and due to open injury, there is chances of infections, and it leads to septic shock. Then what is the phases of trauma care? The phases of trauma care is divided into 6 phases, phase 1 to phase 6. In phase 1 is the triage phase, that is categorizing the patient to priority basis. Phase 2, primary survey, resuscitation. Phase 3, secondary survey. And phase 4, stabilization. Phase 5, transfer and definite care, phase 6. This is the patient care timeline for polytrauma. Concept of initial assessment. So these phases will be started from phase 1, that is triage. The assessment should be done. Preparation phase, triage phase, primary survey, resuscitation, adjustment of primary survey to resuscitation, secondary survey, adjacent to secondary survey, continued post-literacy surveys, and definite care, the last stage, so that whatever the definite care. So preparation pre-hospital phases, coordination to emergency medical service with hospital physicians. At this spot, if there is any injury, you immediate dial to the emergency numbers. So this page will start from the time of injury, mechanism of injury, and patient history, airway maintenance, control of bleeding, shock, immobilization, and immediate transport to the closest appropriate facility. This is the pre-hospital phase. Next step was the triage. Triage is the second stage. So here, triage is to categorizing the patients to whom we give the immediate care, to whom we will give late care. It will measure the vital signs. Step 1, the vital signs. GCS, respiratory rate, systolic blood pressure, and rapid, sorry, RTS, that is less than 11. If these things is there, so we'll give to the trauma center, and if everything is okay, GCS is normal, systolic pressure is normal, or all things are normal, then we'll take to the patients to the, there is no nothing's to be done, we will assess for anatomical injury. So what is the RTS? That is your revised trauma score. So this is the guidelines for revised trauma score parameters, respiratory rate, and here given the points, systolic blood pressure, given the points, and Glasgow coma scale, given the points. So revised trauma score is calculated, points for respiratory rate, for plus points for the systolic blood pressure, for points for the Glasgow coma score. The maximum score indicating least affected people are 12, but minimum the most affected. If the score is minimum, the more the less is the score, the person is mostly affected, or the more is the severity of the patients. Then triage, first one assessment of the, second one is triage decision. So assess the anatomical of the injury according to pelvic fracture, flailed chest, 2 or more proximal long bone fractures, combination trauma with bones of 10%, or inhalation injury, all penetrating injury to head, neck, torso, and extremity proximal to below. If yes, if these are present, then take to the trauma center. If no, then evaluate for evidence of mechanism of injury and high energy impact. Next, step 3, evaluation for evidence of mechanism of injury and high energy impact. Like if the patient is ejected from automobile, of death in the same passenger compartment, if one evaluation of these things. So one, suppose in one apartment, the one passenger is death. So if a person is sitting at that compartment, this person coming to under this state, the pedestrian thrown or run over, high speed auto crash, or major auto deformity is there more than 12 inches. These points are present, then take to the trauma center, otherwise take to the primary care center. Next, how to start triage. The start triage is patient breathing, then no or yes. If the patient is not breathing, then opens patient airway, and is patient breathing, open patient airway, then if breathing, then no. If immediate care. If there is no breathing, then the patient is declared as death. Then if breathing is there, then assess the breathing. If more than 30 beats per minute or less than 30 beats per minute, 30 per minute, then if more than 30, the rate of respiration, provide immediate care. And if less than 30, then assess for the radial pulse. If pulse is there, then assess for mental status. Then if no pulse is there, then rate of respiration is less than 30 and no pulse. Then you can control the bleeding and immediate care. Then if there is pulse is present, then assess mental status. Then if mental status, assess the mental status, can patient follow commands? If the patient is following commands or not. If patient is following commands, then you can delay the care. And if patient is not following the commands, patient is semi-conscious, unconscious, then immediate care you should provide. Then in hospital phase, plan. So here you can preparation phase, tries primary survey. You can have a look to their sites. Resuscitation adjacent to the primary survey, secondary survey, adjacent to secondary survey, then post resuscitation and definite care. So we are under. Now it is hospital. Now the patient is arrived at hospitals after emergency given on the sites of the injury. Tries if the patient already there is accident or disaster, the victims are reached on the before getting to the hospitals. So whatever the management up to trials that is finished, then after trials we have to come to the patient to the categorize the patients and receive the emergency department who needs emergency care. Then planning for arrival, trauma room is there in hospital phase for resuscitation, for monitoring, for wound solutions. Trauma staff is there. Laboratory radiology personnel are there. Personal protections you should use for protect PPE used for prevent hepatitis and AIDS. The minimum precautions should be followed in the emergency, in the hospitals. Casualty, that is face masks, protection, all things you know. PPE. Then ATLS. At the when the victims reaches those after trials, you categorize the patient who need emergency care. Then uh, after shifting the patient to the emergency care, there is emergency medical teams. They should provide immediate ATLS. What is ATLS? What is ATLS? ATLS is Advanced Trauma Life Support. So here primary survey identify what is killing the patient, resuscitation, treat what is killing the patient. Secondary survey proceed to identify other injury and define definite care, develop a definite management plan. The primary survey emergency when the clients reach at the emergency department. So according to CAB or ABCD here, it should be assessed A for airway, breathing, circulation, disability, exposure to environment, or D for disability limitation, defibrillation, exposure to environment and fracture, stabilization or Foley's catheter is required. The primary survey, airway management, if conscious, if unconscious, these things should be assessed. So airway is assessed by these two maneuvers, jaw thrust maneuvers with hyperextension of the necks. In one hand, should push down to the forehead, and in another one, you will thrust the jaw. This is not the position actually. Here, you should thrust. Take the lower chin upward. It should be upward. Then this is chin lift. This should chin lift like that. This is the jaw thrust. These things. This is head tilt. Head tilt. Head tilt. Chin lift. Head tilt. Chin lift. Then jaw thrust maneuver. Then after hospitalization, primary survey. These things you need to know: breathing, ventilation, exposure, inspection, auscultation, palpation, pulse oximetry. It should be done in the emergency rooms. And life-threatening conditions may be there: cardiac tamponade, tension pneumothorax, open pneumothorax. So breathing. Then breathing ventilations, like if the patient require ventilator, they can also give. Then circulation, assess for ABC, assess for irregular breathing. Then C assess the blood loss, resuscitation, arrest bleeding, often vascular assay, external or obvious internal bleeding is there, you should assess if there is blood loss. Then how will you assess the C or circulation or bleeding? Pulse, by applying pulse, radial pressure, systolic blood pressure, 90, femoral pulse, epic carotid pulse. So largest blood loss in thorax, abdomen and pelvis and extremities. So initial management, that is fluid therapy. In adult, 2 liters of ringer lactate solution as initial fluid for the talents. In children, 20 mg per kg of body weight should be given. So immediate and sustained return to vital signs. Response to initial fluid challenge are immediate and sustained return to vital signs. Transient response with later deterioration or no improvement. These may be the possible conditions. Maybe the patient vital sign improve, may patient go to deterioration, immediate response and later deterioration, or no improvement may be the conditions. So these are the general signs for inadequate tissue perfusion: urine output less than 0.5 ml per kg per hour in adult, or acid base imbalance. So these things we need not to be discussed. Then after C, that is the D means disability limitations. So D for disability limitations. Assess for, you should assess ABPU, alert, patient alert or not, response or not, response to pain, voice, or that is GCS score. You have to assess for GCS. This is rapid assessment, motor and sensory functions. Next, D for also decision making. To whom you will admitted in the hospitals, who needs critical care, who needs secondary assessment. After primary assessment, if the patient is okay, then you keep in observation and do again secondary assessment. And if the patient needs critical care, you should admit the patient in critical care unit. This is the two response. Then E for exposure. Undress for assessment. After assessment is completed, it is imperative to other patients with warm blankets and external for 1 week. IV should be warmed before infusion and warm environment. Or E, also in E there is the emergency drugs should be given. Then F for fast. So that is focused assessment with sonography for trauma. After the patient stabilizes, who may need critical care in ICU or who may need for observations. So you should keep the patient after the patient is stable. For example, if the patient needs critical care, needs intubation, needs ventilator, then after stabilizing the patient, you should go for fast. That is focused assessment with sonography for trauma. Abdominal fluid, you should go send the patient for sonography to accurate or to determine what is the more conditions, if there is fluids, if there is air, or if there is hemorrhoids, etc., or intra-abdominal fluids, or any internal hemorrhage, you have to calculate, identify. So this is all about under primary survey. Then secondary survey does not begin until the primary survey is completed. So primary survey A, B, C, D, E has completed. Then head to food evaluation. Again, after primary survey, you have to again evaluate the client. That is complete history, physical examination, or reassessment of the vital sign. All these things ample. That is allergy, medications, past illness, last meal, and event and environment. So secondary assessment after in primary assessment we will stabilize the patient, and secondary assessment we will do head to food examination, like which things is abnormal that all of you know. So these are the trauma team members: trauma leader, anesthesia, general surgeon, orthopedic surgeon, emergency department physician, anesthesia, nurse, radiographer, etc. There is a guideline. So this is the 6 star of life: preserve life, prevent further injury, promote recovery. So there is a star. Early detection. Star has six sides, 6 stages. Early detection, early reporting, early response, good on-scene care, care in transit, and transfer to the definite care means hospital. Jota we have already told. So this is all about polytrauma. So any doubts is there regarding polytrauma? We have discussed what is polytrauma, different types of polytrauma, what is the etiology, pathophysiology, what is the signs, symptoms, and what is the management of polytrauma. So management little bit critical. First of all, we'll if you not remember these steps, simply you can remember first aid management, then acute management or emergency management, then that is primary management and secondary management. So next time limitation is there. We'll go to multi-organ failure. Yeah, shock is there also. Triage is there. So we'll discuss what is triage. Triage we have already discussed. So what is triage? So what is triage? Triage is one thing. So actually, it in 1 to 2 hours, it will difficult to finish or to cover all those blocks. So triage is that. What is triage? Triage is the process of prioritizing the patient treatment during mass casualty. In polytrauma, we have all discussed ATLS, that is advanced life support, advanced trauma life support. So what is triage? Through triage, we have read many things. That is triage. So what is triage? Triage is the process of prioritizing patient treatment during mass casualty. Anywhere, if there is a disaster, if there is any mass accident is there, so there will be a lot of patient injured or affected. But the way, the process through which we can prioritize the clients who needs emergency care, who needs the definite care, or who needs late care, or who doesn't need any care, those patients are dead. So we should not waste our valuable time by giving our time to them. So what is triage? Triage is the process of prioritizing patient treatment during mass casualty events. The patients are classified according to the type of urgency of their condition to get the right patient to the right place at the right time with the right care provider. So what is triage? Triage actually a French word that's meaning is to search, to identify, to refers to the process of rapidly determining the patient acuity. It's the condition to determine which patient needs the acute care. So Samran Kolle have raised your hands. Okay. So triage refers to the process of shutting sick and injured, shutting down who is requires urgent, who will need delay care, and the type of conditions so that they can be routed to the appropriate facilities for medical treatment. So the aim of triage is to, so everybody understood what is triage?
Yes, ma'am.
Yes, ma'am.
The aim of trials is to ensure the patients that are treated in order to their clinical urgency, to ensure that treatment is appropriate and timely, to allocate the patient to the most appropriate assessment or treatment area, that is avoid congestion. So, in one, if we'll to separate the patient, the aim of trials is to separate the separate or to categorize the patient who need emergency care, who need delayed care, and who doesn't need any care, or to provide ongoing assessment, not only for providing a rule out for identifying the category, but also the aim of trials is also to provide ongoing assessment. That means if now the patient is stable, then after 1 hour also we have to observe. We have to again reassess whether his or her condition is deteriorating or improved. To provide information to patients and families regarding services. So it is also services, expected care and waiting times. For example, after a mass casualty or after a disaster, by separating trials, you have keep the patients separate, and it is also your role to inform the patients and families regarding which type of service they need and their waiting time when they will get the treatment. To contribute information that helps define departmental acuity also. So types of trials. The trials are divided into three types. One is primary trials, secondary trials, and tertiary trials. So the primary trials, that is called as field trials, that will be given in the point of happens, point of happenings, or at the point of disaster occurrence. So that is divided into two stages, that is start trials and safe trials. That is in the disaster scenario, that is early transportation, start and safe disaster scenario. The secondary trials is otherwise called as ED trials or emergency department trials, timely and appropriate intervention color coding. This is in the emergency department. So this is transport, to whom will shift emergency department, to whom will keep in the trauma center and will give accurate care. Then when we'll send the patient to the casualty or hospital settings. Then at that time we scare the trials, that is called as color coding also there. Then tertiary trials, the specialty trials. So first come to primary trials and start and safe trials. So anybody have an idea regarding start trials? What is start? Start and safe. This is the primary trials. So start trials means simple trials and rapid treatment technique. It is done, start trials is done at the field by rescue personnel. Quick assessment of respiration, perfusion and mental status. The start trials, we have already discussed these things in the polytrauma management. Shall we repeat it? No. Next step. After primary assessment, that is start trials, that is simple trials and rapid treatment technique, that is quick assessment, that is done in the field. So what will done? Secondary assessment. After that, secondary assessment of the victim. When the patient sad, SAM means secondary assessment of the victim endpoint. When the patient are likely to have significant delayed transport from a scene, number of casualties exceeds transportation capacity or damage to the hospital infrastructure. So if at a time we will transfer the patient to the hospital, then what will happen? There will be over congestion and there will be the care will be hampered. So it will help to identify the patient who are most likely to benefit from the care available under the assured field conditions. So those who need care, emergency, the start trials will identify that. Then the safe trials will delay the transportation of the patient by keeping them at the field and continuing the assessment and care. This is the safe side, safe trial. It will identify, it will send, it will continue care and delay the time of transport. Reflect a balance between resource use and probability of survival. In safe trials, what you will do, you will again assess, continue your assessment, vital sign, airway, chest, abdomen, pelvis, spine, extremity, skin, neurological status, and mental status. In safe trials, you keep the patient along with you and continue assessment, and those who need emergency care, you will send them for casualty. So there is a coding for safe trials, that is 1, 2, and 3. The patient will die regardless of how much care they receive. जहाँ भी care दियाଯିବ, whatever the care is given, there will be no improvement. He will be die. So you should not send them to the hospital settings or emergency department. We will only provide them comfort care. That is category 1. In category 2, the patient who will survive, whether or not they receive the care, that is the delayed care. Anytime, if will survive whether or not they receive care. If they will receive care or not receive care, but they will survive. So the trials will give delay care, and that is category 2. And the 3, that is in the red mark. That means the immediate care, those are needed immediate care. The patient who will be benefit significantly from extra field of intervention, immediate care, urgency, that will be under 3 categories. That need immediate care, and they will send the patient immediately to the emergency department, to the hospital facility. So these things is understood. So there is safe trials guidelines, cross injury, or for cross injury or lower extremity, patients are assessed using the MES score, that is Mangled Extremity Severity Score, scores of 7 or more, then amputate. You have to amputation is essential. But if the score is less than 7, attempt limb salvage, immediate transport. Then head injury. Use Glasgow Coma scale. Here you can use for cross injury, lower extremity. You can use MES. That is a score is there. If more than score, patient need amputation. And if less than score, patient need immediate transport to save the limb. Then head injury. If the patient is head injury, in head safe dress, you will assess for Glasgow Coma scale, GCS. If score is 8 or above, then treatment is continued. Better than 50% chance of a normal or good neurological recovery. If score is less than 7, that is 7 or less, then comfort care only. And burn injury, less than 50% chance of survival. 70% TBSA burn, age more than 60 with inhalation injury, age less than 50% chance of survival will continue this criteria. Then abdominal injury, no data to guide evaluation, 4 ml per kg for hypotonic saline, and 2 IV fluids should be given to reduce hypotension. If no response, only comfort care. Then this is the primary trials. Then secondary trials. I have told you the primary trials and secondary trials. Yes, the start and save completed. You can categorize the patient, identify a patient, and those who need immediate care, you have to send them to the emergency department. So now the time comes for the hospital care. That is emergency department trials 2. So secondary trials. So emergency department polytrauma, we have discussed all the 3 trials, establishes priorities for care, determines the clinical treatment. Even the trials has assessed the scene. L, it should be again identified in the emergency department. Triage is needed at the emergency department entrance. To accomplish the most good for the most number of patients, the triage team should evaluate the patient arriving at the emergency department and classify again according to severity. In emergency department also, suppose there are 20 patients coming to the from the primary triage, they send 20% to the secondary triage, that is to the emergency department in the hospital. So again, in the emergency department in the outdoor, they have also classified according to the severity of the conditions and injury. So triage area, in every hospital there is a triage area. So assessment, examination, communication and privacy. So equipment required for assessment, emergency equipment, standard precaution, adequate communication device, telephone. You should inform to the relatives and facilitate recording triage information. Everything you have to record. Triage team, physician. In hospital, there is a triage team, that is a physician, and emergency department nurse is there, medical records are very important, and admitting clerk, and should receive the patient. The physician performing hospital triage should be acknowledged as being in command of the triage area, should be clearly identified by specialty colored vest on the garments. So in a triage, color coding is there. They given definite colors like yellow color, red color, and black color. Those who are black dead, they use black color. Those are need very emergency care. They put a band like a red band on the wrist and yellow band, so green band. Those need delayed care. So trials will identify, and with identifying a band, they will send to the patient to the hospital. So by looking at the color code, the physician will decide and again reassess, then provide care accordingly. I need to cover. There is also in emergency department 4 color code again: red, yellow, green, and black. So I'm giving these things to you. Red, that is first priority; yellow, second priority; again green, third priority; and black, dead. So no need to give any care and no need to waste any time. Some place, so this is under this category. But the red one first priority, yellow second priority, green third priority, red one first priority most urgent, second priority urgent, third priority non-urgent. So most urgent, those cases hypoxia, life-threatening conditions, then given immediate care. Then urgent, systemic medicines injury have systemic implications like shock conditions, hypoxia conditions, and the patient can likely withstand 45 to 60 minutes wait without immediate risk. But in red category, most urgent but first priority tries, without starting immediate care, the patient will not survive. The patient will die. But here the patient can, in yellow zone, the yellow color coding, the patient can urgent but not most urgent, and it's the second priority. And the patient, if the treatment is delayed for 45 to 60 minutes, the patient can live or patient can survive. But non-urgent or green color, they will stabilize without any injury. With a minimum of care, they can stabilize the patient. So we can start the care late for non-urgent patients. So after red color will give importance, then yellow patients, then yellow color, then green color, then black color. They are death patients, no need to start the care. Then there is a triage tag. This color tag, the patient will wrap with herself. The critical, there will be some signs to whom you will assign critical. You will have all these things in your books. Documentation. After in hospital care is started, you have to document the date and time of assessment, name of the doctor, chief present complaints, what is the limitation, what is the history, what assessment were findings, what is initial trials category allocated. That means when the patient is coming to the hospital, she or he was under which category of trial, and now the patient is under which category, or any investigation or first aid or treatment, whatever you started for the clients, you have to all these things documented. So this is the contaminated like cards. You have to price tag. Everything is written here about the client, patient name, patient address, everything you have to. So retries. After the patient is stabilized, again retries means his or condition changes while they are waiting. So in waiting room, some patients in trials, some patients are shifted to the hospitals, and some patients are also remain in the trial center and wait, being waiting for the treatment or for shifting to the hospitals. So this additional relevant information becomes available that impacts on the patient's urgency. Both initial trials and any subsequent category should be recorded. So what happens? Monitoring or close observation, each condition is deteriorating or improving, it should be documented in the trial center. Then what is tertiary trial? Tertiary in field, that is primary trials, in hospital, that is secondary trials, and tertiary trials after initial resuscitation and stabilization in the emergency department, and that is secondary trials. Tertiary trials started by the specialist. Suppose after giving secondary trials, it is also identified that the patient is having what, pneumothorax, or it will having cardiac tamponade. So in specialist, that is the tertiary trials, not by emergency physician. It should be assessed and allowed, and the patient requires special services like cardiology, neurology, or respiratory. So these are the special category of trials, that is tertiary trials. It requires admission to intensive care unit wards and can be discharged from their sites. So take a message. Each and every emergency department should have their well organized trials plan to tackle mass casualty or disaster scenario in the hospital, and pre-designed trials team along with training of the all staffs like doctor, nurses, and other health care providers to be pursued in every hospital. Okay, so next, I think it's time. So shall we continue or will you stop here?
No, ma'am.
We'll stop
It's
here.
too. Yes, ma'am.
Actually, so many things are there. One block is assigned in one class, so it's not.
बहुत ज़्यादा है.
Even if I want to clarify all these things, but it will take more time. So within block shock is remaining there. There is multi-organ failure. Also, there is what anything that is 10, 12 classes are assigned, but it may need some more classes. It is also in the instructions are there. We can add 1, 2 classes also.
Okay, ma'am.
One thing remain trials coding over, complete multi-organ failure remaining, and shock, septicemia will be there, DIC, drug overdose, drowning, poisonous, and anaphylaxis, all these things are there. So I can't cover that things the next class if there is the time. So can we continue, or you can read, or any doubt you can ask also in WhatsApp or in the group. You can continue your rest of the portion. And your material is very nice. All things are written here very clearly. You can just fundamental, we are clarifying or giving some information. For other things, you can follow up your books. So
Okay,
any
ma'am.
doubt if people are having, or we'll close the class. Okay, so shall we leave?
Thank you, ma'am.
Okay, thank you. I'm leaving now.
Okay, ma'am.
Okay, thanks all.